This is the Today we are going to talk about bleeding disorders. In normal physiology, in order to stop the bleeding, there should be an integration of the function of four main factors. First group is the clotting factors. Second is platelets. Third, blood vessels, and especially the endothelial layer. For blood vessels, they can be associated with bleeding in several diseases. No specific disease that can affect the blood vessels only. In some connective tissue diseases, those are a group of diseases that can be inherited or sometimes acquired, or can be associated with autoimmune diseases like the rheumatologic diseases. The chronic steroid intake will weaken the blood vessels and increase the chance of their rupture. Systemic amyloidosis. The amyloid protein will infiltrate through any organ and can cause physical damage, and among them are the blood vessels. Vasculitic infections. There are some bacterial and fungal infections that can affect the blood vessels, like the spirochetes and some fungus. Those can make vasculitis and sometimes aneurysm, which result in rupture and bleeding. Vitamin C deficiency. The old name was scurvy. This is an almost outdated disease. It was common in the past, but these days it is much less common. Vitamin C is important for the structure of the collagen in the blood vessels, and thus when it is deficient, it will weaken the blood vessel and results in bleeding. So in these patients, they have bleeding in the superficial parts of the body, which is the skin, and we call the bleeding there as petechia if it is a small area, or ecchymosis, which is a large bruise. So in the skin, these diseases will manifest as bleeding in the skin and the superficial mucous membranes, like in the oral cavity. Now we will talk about platelets-related bleeding. Bleeding secondary to platelet disorders. It can result from a numeric problem, like a decrease in the number of the platelets, and we call it thrombocytopenia. The most common disease is called immune thrombocytopenic purpura. We are going to talk about it. And patients with AIDS, they have damage to the megakaryocytes in the bone marrow, and this will result in thrombocytopenia. In some cases, thrombocytosis, in contrast, paradoxically, the platelets are large in number, but they are not functioning and cannot function properly, and this is common in myeloproliferative neoplasms. We are going to talk about it in the neoplastic part of the white blood cells. So the platelets are dysfunctioning, although they are large in number, and the patients have a chance of bleeding. How do we test the platelets other than the number? For the function, there is a test called the bleeding time, in which we make a small cut in the superficial part of the body, like in the ear, and we wait until the bleed stops. This test is obsolete. It is rarely used these days. Instead, we have two tests. They are platelet aggregation test and the von Willebrand factor test. The von Willebrand factor is essential for the function of the platelets. So we make the both tests at the same time. We add a material. It's called ristocetin. This is an antibiotic, and it can cause an artificial platelet aggregation, but it needs the presence of von Willebrand factor. So if we add it and platelets, they do not aggregate, then we know that either one is abnormal. Either the platelets, they cannot function well, or the von Willebrand factor is missing. So if we do the von Willebrand factor test and it is there, it is functioning, then we know that the platelets, they are defective and cannot function well. So the patient will have abnormal platelet function factor. Back to the diagram. Here's the von Willebrand factor. It is located beneath the endothelium. So when the endothelium is damaged and removed, the von Willebrand will be exposed. It binds to the platelet by glycoprotein 1b. So the platelet plug can anchor at that site. If it is deficient, then the platelets cannot bind the defective place and the patient will have persistent hemorrhage. These patients also have structural abnormalities. The platelets appear larger than the normal, and they can show thrombocytopenia. These are associated findings in this disease. How do we diagnose both syndromes? By flow cytometry. Remember this test, it examines the antigen on the surface of the fluid cells. So in this patient on the left side, these are the platelets. As you can see, it doesn't move to any of the markers, CD61 and CD41. They do not go to either direction, which means they are deficient of both of them. So this patient has Glanzmann disease. While in this patient, we examine CD42B with CD61. As you can see, the platelets, they move to the CD61, which means they are normal, while CD42, it is deficient. It doesn't go up. If it is located here, then the patient has a normal platelet, okay? While if it is deficient in CD42B, then it doesn't go up, it stays down. So this is how we diagnose both diseases, by flow cytometry. So in the peripheral blood, as we mentioned, large platelets, while if we take a biopsy from the bone marrow, we can see the megakaryocytes intact and they are increased in number to compensate for thrombocytopenia. What about the spleen? If we do a splenectomy and we examine it under the microscope, we see large aggregates of B lymphocytes and plasma cells, which are responsible for secreting of this autoantibody. So this is immune thrombocytopenic purpura. Okay, purpura, it means the bleeding in the skin. Another disease, it is acquired one from its name, heparin-induced thrombocytopenia. This disease appears in around 5% of patients who receives the unfractionated heparin. Heparin is commonly used in medical practice as an anticoagulant to stop coagulation and prevent it. There are two forms of platelets. There is a big one, large one, it is called unfractionated, and there is another one which is an improved one, which takes only the active site of the heparin. That one is called fractionated or low molecular weight heparin. This syndrome is most commonly appears in the unfractionated large molecular weight heparin. For unknown reason, heparin induces synthesis of IgG antibodies that target another protein in the platelets cell membrane. It's called factor 4. So these immunoglobulins will bind these antigens on the surface of the platelets. They causes platelet aggregation inside the body and formation of a thrombus. Okay, they cross-react the platelets to form a spontaneous thrombus. So the patient has paradoxical thrombocytopenia with thrombosis. Okay, remember we mentioned this in paroxysmal nocturnal hemoglobinuria, but in that one the platelets, they lyse, they are torn and lyse, and the content will promote the formation of the thrombus. In this one, the antibody will cross-react platelets together to form a thrombus, so the patient will end up with thrombocytopenia and thrombosis. In some rare cases, it can also appear in the low molecular weight heparin, but much less common. Next, we have thrombotic microangiopathies. There are two main diseases that result in this syndrome. The first one is called thrombotic thrombocytopenic purpura. Okay, don't confuse it with idiopathic thrombocytopenic purpura. This one, we have thrombosis everywhere in the body, which results in thrombocytopenia because the platelets are consumed in forming these thrombi. Another clinical syndrome is called hemolytic uremic syndrome. They have different pathogenesis, but they end up with similar findings. In TTP, patients commonly have a pentad, 5 symptoms: fever, hemolytic anemia, thrombocytopenia, neurologic symptoms, and renal failure. This is the typical presentation, 5 findings. Okay, but you will find later in the future that not all of them are full-blown and very prominent. Most patients, they have absent one of them, or it is present but in a minor condition. So you have to know the 5 symptoms of TTP. In hemolytic uremic syndrome, it is similar, but in this one, the dominant symptom is the renal failure. Okay, patients present with renal failure, and they do not have neurologic symptoms as in TTP. HUS is common in children, while TTP, it can affect any age. In both diseases, the small circulation in the body, it is filled with thrombi, platelet-rich thrombi. Okay, and these thrombi are small, obstructing the small circulation, so the patient will have thrombocytopenia at that time. The clotting factors, they are intact, they are not active, so when we examine the tests when we do the test that examine the clotting factors, which are the PT and PTT, they appear normal. Instead, the patient has thrombocytopenia. Okay, what is the pathogenesis? There is a long talk about this, but we will summarize it. In TTP, there is a deficiency in a blood protein. It's called ADAMTS, ADAMTS13. What's the function of this protein? It converts the precursor of von Willebrand factor and gives us the von Willebrand factor, which is important for platelet plug formation, as we mentioned. So when ADAMTS is absent or not functioning, then the von Willebrand factor will stay in its precursor form. This precursor form is a large multimer. It is very large. Normally, it has a short half-life because it is dissected by ADAMTS. So it stays in the blood in this large form, and it is capable of binding so many platelets together. So it forms a spontaneous thrombus. Okay, this is the pathogenesis of TTP. In hemolytic uremic syndrome, it is a different scenario. This is caused by infection by a strain of E. coli. It's called enterohemorrhagic E. coli. This one, it is contaminated. It appears in contaminated food. It secretes a toxin called chegatoxin, which is most concentrated in the kidneys. Okay, at that site, it causes endothelial damage and it promotes thrombosis there. So the patients will have so many thrombi similar to the TTP. In both situations, if we examine the blood film, we will find schistocytes. We described it in the previous lecture. Schistocyte results from direct damage, physical damage to the RBCs, and the damage is caused by the small platelets. Okay, when the RBC passes through these thrombi, sorry, not platelets, thrombi. When the RBC moves through these small thrombi, it is broken. So schistocytes will appear in peripheral blood in a large amount, and also the patients will have thrombocytopenia because they were consumed in the formation of thrombi. We finished the platelets. Now we'll move to the clotting factors. We call it coagulation disorders, which are related to the clotting factors. There is a problem in the function of the clotting factors. It can be inherited, or more commonly, it is an acquired situation. For example, for acquired one, if the patient has a vitamin K deficiency, okay, vitamin K deficiency, it can be dietary, but more common it is related to drugs. And the most important drug is warfarin, okay? It causes a deficiency in the, it blocks the synthesis of clotting factors that need vitamin K. So both situations are similar. Vitamin K is rich, is present in large amount in the green leaves like spinach. So patients will have decreased synthesis of factors اللي هم related to vitamin K اللي هم 10, 9, 7, 2. Remember the year 1972 for any memory, 1972. So these are the clotting factors related to vitamin K. 2 is the prothrombin. In another situation, liver disease, because liver is the responsible organ for synthesizing these factors, so patients will have commonly bleeding. Disseminated intravascular coagulation, we will talk about it. In this disease, there is a consumption of all clotting factors, okay? And in some situations, an autoantibody that binds one or more of these factors, so the patient will not have a true deficiency. Instead, the function is not there. It can affect single or multiple. How do we test the clotting factors? First test is prothrombin time, PT. This one assesses the extrinsic pathway, and the most important ones are factors 5 and 7, in addition to factors of the common pathway, which are 10, 2, and fibrinogen. The other test is partial thromboplastin time, PTT. This one assesses the intrinsic pathway, the remaining clotting factors, 12, 11, 9, 8, 5, and in addition to the common pathway. So the main difference is in factor 7. Okay, in addition, as we mentioned, sometimes an autoantibody can interfere with the function. So if we examine these tests, let's say the patient has prolonged PT only. Okay, so we have a deficiency in one of these factors, while the PTT is normal, so it's most likely either 5 or 7. Next, we do another test. We call it mixing test. Mixing test helps us differentiate between the true deficiency, if it is absent, from the presence of an autoantibody, which is called inhibitor. We bring a normal serum and we add it to the patient's serum. Then we repeat the test. If there is a true deficiency, then we compensated. We added the normal deficient factor. Okay? If the PT or PTT test that was abnormal, if it is corrected, then the patient has a true deficiency. However, if there is an autoantibody, it will block the new added factors, so the PT or the PTT test will remain abnormal. Okay, this is a simple blood test. Now we will talk about diseases of the clotting factors. The most common one is called von Willebrand disease. This is inherited as an autosomal dominant form, and it has many different subtypes. So it is the most common inherited bleeding disorder, affecting 1% of population, and the patients will have spontaneous bleeding in the superficial parts, because von Willebrand is important factor is important for the function of platelets. Also, patients might have menorrhagia in women, which is excessive menstrual period. For von Willebrand factor, it is normally widespread and vast. The sources, it is synthesized inside the endothelium in bodies called Weibel-Palade bodies. Also, it is present below the endothelium as an anchoring protein and inside the platelets. It circulates normally in the plasma carrying factor 8. This is important. In addition to these sites, there are stable ones. It can circulate the plasma and it carries the factor 8. After endothelial damage, as we mentioned, when the endothelial cells they are damaged and torn away, the subendothelial von Willebrand factor will become exposed and it binds the platelets through glycoprotein 1b, which is CD42b, forming the platelet plug. And as we mentioned, we can make this test in vitro by adding ristocetin, which activates the von Willebrand to bind the platelets. So we can check for both of them by doing this test. Okay, von Willebrand disease. In the disease, when the von Willebrand factor is deficient, there is a compound defect. First, the platelets, they cannot aggregate because they need von Willebrand factor. So the patient will have, as we mentioned, a disease related to the platelets. They are not functioning, so the patient will have superficial bleeding. And in severe cases, in severe forms, as we mentioned, the factor 8 is carried by von Willebrand factor, so the patient might develop a deficiency also in factor 8. So the symptoms in most situations, they are related to the platelet defects, so the patients will have superficial bleeds. While in the severe form, which is the homozygous situation, when we have markedly decreased von Willebrand factor, so the factor 8 will also be deficient and the patient will have clinical syndrome similar to the hemophilia. Okay, we are going to talk about it. So absent factor 8 will cause prolonged PTT and the patient will have another form of bleeding different from the platelets. In hemophilia, the clotting factor deficiency, the bleeds tend to occur in the body cavities, not in the skin. There are, as we mentioned, many types of von Willebrand factor disease. The first type, which is the most common, as we mentioned, we have a decreased amount of the circulating von Willebrand factor, so the patients will have non-functioning platelets. In type 2, there are two forms, A and B. In type 2A, the pathogenesis is different. In this one, we do not see the high molecular weight multimers, the precursor of von Willebrand factor. It is not there. These patients, they have absent multimers. In 2B, the multimers, they are present, but they have abnormal function. They are hyper functioning and they have a short half-life at the same time. So they causes an alternate problem. They consume platelets more often. In these patients, as we mentioned, the platelets are there, but they cannot function. In this subtype, the multimer, they bind many platelets, okay, causing mild thrombocytopenia, mild persistent thrombocytopenia. Remember, this is the pathogenesis of TTP, but in that one, it is widespread and it is severe. While in type 2B von Willebrand disease, these multimers, they consume some platelets, causing mild thrombocytopenia, but without formation of thrombi. So this is the difference between the three types. Next, we have hemophilia A. This is the second most common inherited bleeding tendency. It is an X-linked disease, so it is mainly a disease of boys, but also can affect girls. The other name is classic hemophilia, also known as classic hemophilia. It It is the most common hemophilia. Patients will have a reduced factor 8. It can affect females, as we mentioned, if they have random inactivation of X chromosome in the normal chromosome. In 70%, there is a family history in the maternal uncles, okay, or brothers, while in 30% there is no family history, so it means a new mutation in that person. Patients mostly have mild deficiency, okay. Normally we have excess amount of factor 8. The symptoms appear when there is a marked deficiency, okay. Let's say around 20% of the normal amount of the normal levels of factor 8. At that time, symptoms will start appearing. So symptoms will appear mainly after trauma, okay. The bleeding appears after trauma, especially major surgery, okay. And surgery can occur in boys early in life, okay. The circumcision, tathir, it is done early in life, so if that boy has hemophilia, he will develop excessive bleeding after that surgery. Now some patients, they have very severe bleeding. In those, the level of factor 8 is below 1% of the normal one. These patients might have life-threatening bleeding and they can die, secondary to severe hemorrhage. In 10% of the patients, they have the normal level, but the function is not normal. They have non-functioning factor. The characteristic of hemophilia, which is the deficiency, the clotting factors, not the platelets, that the bleeds tend to occur in deep tissues, okay, like in the soft tissues, muscles, or in the body cavities, especially in areas with mechanical stress. Most common is in the joints or other body cavities. So this bleeding is more problematic to the patient than the platelets-related one. As a growing child, the repetitive bleeding in the joint will create a deformity in that joint. So skin petechia is absent. This is characteristic of hemophilia, and patients will have prolonged PTT because they have deficiency in factor 8. This one is corrected by mixing study. It is an inherited deficiency and not related to an inhibitor antibody. We have another test called the specific assay. We can test the factor 8 by itself, if it is there or if it is functioning or not. This is a new test which differentiated from the coming disease. The next disease is hemophilia B, also known as Christmas disease. It is less common, much less common than hemophilia A. It is caused by a deficiency in factor 9. Okay, it has also a factor in the intrinsic pathway, so it will result in a similar disease. This one is X-linked, much less common than hemophilia A, and clinically similar to hemophilia A. If the deficiency is mild, then the patient will have excessive bleeding after major trauma. When it is severely deficient, then the patient might have life-threatening bleeding. Again, the patient will have prolonged PTT corrected by mixing study, and to differentiate it from hemophilia A, we do factor assay test. The last category is the endothelial-related bleeding. The most important disease is called disseminated intravascular coagulation. Again, in this disease, we have widespread endothelial damage, which results in formation of microthrombi in the entire body. So these thrombi will consume the clotting factors, okay, although they form thrombi, but the clotting factors are consumed. It is part of the pathogenesis of the disease, not only the platelets, but also the clotting factors. So the patient will have thrombosis everywhere, but after that they complain paradoxically from bleeding because there are no clotting factors. They are all consumed in the formation of the thrombi, and the body will do not have normal clotting factors. So this is the difference between DIC, disseminated intravascular coagulation, and the microangiopathic hemolytic anemias اللي هم TTP and the hemolytic uremic syndrome. In this one, additionally, we have consumption of clotting factors. So the patient will have prolonged PT, PTT, both of them. There are no clotting factors. And the consumption exceeds the capability of the liver to synthesize new one. So the patients will develop life-threatening bleeding. Okay. In the blood film, we see again the schistocytes. We have commonly anemia and thrombocytopenia. Okay. But the difference from TTP is by examining the PT and PTT. In this one, they are prolonged. In that one, they are normal. What are the causes of DIC? There are so numerous causes in general. Okay. In general, there is a secretion of a tissue factor. Tissue factor, it is secreted from the damaged endothelium or sometimes from outside sources. But we have damaged endothelium like in septicemia or viremia. Okay, the viremia can cause DIC, and now we hear about the COVID-19 that can cause DIC in many patients. Snake venom. Sometimes in complicated labor, there's a production of tissue factor from the placenta. Tissue factor, as we mentioned, it starts the formation of these thrombi. Tissue factor is normally secreted from the endothelium. It is present there. So in some situation, the endothelium by itself doesn't secrete this tissue factor. Instead, it comes from outside sources, like in placenta in certain situations. So this is called a complicated labor. In some women, when they during the labor, there is a production of tissue factor which can cause DIC and even death. Advanced cancer. Okay, cancer, the most common or the most notorious one are a type of acute leukemia. It is called acute promyelocytic leukemia. These malignant blasts, they secrete tissue factor in a large amount, which causes DIC. Another one, the epithelial tumors that contain mucin. Mucin, when it circulates in the blood, it activates the tissue factors to cause DIC. In severe trauma, okay, including surgery, they can be complicated by DIC. We mentioned the snake venom, and in severe inflammation. And the most known cause is, example is acute pancreatitis, which is a severe inflammation in the abdomen. Okay, it can cause DIC.